Thank you, Neil. That was a great talk. And it again it's very important to remember that when patients have HCC beyond Milan criteria, to still refer them to transplant centers as soon as possible, to any of the 3 transplant centers. It's my privilege to introduce Dr. Dhanasekaran, our next guest speaker. She's going to give us a talk on management of benign lesions. Renu and I had the privilege to work with Renu at Stanford for the last 3 years. Renu completed her schooling in India, but then she completed her fellowship at Mayo Clinic, then completed her transplant hepatology fellowship at Stanford. And we are lucky that she stayed back with us. Her interests lie in translational research, finding molecular targeted treatments for HCC. She's also involved in international consortium about cancer genomics. And in a short span of 3 years, she has multiple awards, and she has given talks at national and international level. She has she has an R01 grant as a co-investigator. She has a Career Development Award by ACG. She has a KO8 Career Development Award as a PI. So she has achieved a lot in a short span of 3 years. And it's my privilege to introduce her to give her the talk.
Thank you, Dr. Kumari, for your kind words. Hi, everyone. So I am the last speaker. Where's the cursor?
That's a good question. I don't know where the mouse is. Can we have AV up here for a moment? The mouse disappeared. Okay. There, thank you. Where was it there?
Okay, so I have the task of a topic that doesn't have too much ongoing research. So this is going to be more on clinical approach, evaluation, and management. I'm not going to show a lot of data from AASLD. I went through the entire abstracts and I found one, which I will show you here today. So, so it's going to be a fun way to end it, I think, because it's more light. So I'll be talking about benign liver masses, evaluation, and management. And after hearing about the more morbid liver diseases, you're wondering, is it very important to also discuss benign liver diseases or liver lesions? And I would say it is, because this is probably what you're going to see a lot of in practice. Why you should care? Because 3 out of 10 patients who get a CT scan or ultrasound or MRI for some reason will be found to incidentally have a liver lesion. So that's a lot, and these patients do get referred to us often. And why are we finding so many of these, what are now called incidentalomas? They have their own name because they just get found when you scan them for something else. It's because we scan a lot. If you look at the study from JAMA, they show that in a 10-year period, the number of CT scans we order has tripled, and the number of MRIs quadrupled. So the more patients you scan, you just incidentally find these lesions. And though HCC is obviously morbid and scary, but most likely you're going to find other causes for the liver lesion that is incidentally found, because liver cysts are very common. The incidence is around 5%. Hemangiomas are the next most common, around 2%. And then from there, it becomes rarer. FNH is another lesion I'll talk about. And if you look in the bottom, you cannot even see the bar for either cancer or adenomas, because they are around 1 to 7 per million. So most likely these are going to land up being benign lesions, but they're going to cause a lot of distress to the patients who show up in clinic because they've been told they have a tumor in the liver, and we are tasked figuring out what to do with the tumor. So I will briefly show a case here, a very regular phenomenon in my clinic. 34-year-old Caucasian have chronic medical conditions, goes for abdominal pain. They try PPI, it doesn't work. Then they do an ultrasound looking for, say, gallbladder disease because she has right upper quadrant pain. And this is the ultrasound. The gallbladder is collapsed, normal. There's no wall thickening, nothing like cholecystitis, no stones. But incidentally, she has a 5.5 centimeter mass in the left lobe of her liver. The lesion is large enough and she has symptoms, so appropriately they follow this up with a CT scan. And a CT scan is read as a 5.5 centimeter lesion, peripheral arterial enhancement, no uptake in the delayed phase. And all of us have seen these reports which favor a particular diagnosis, in this case, atypical hemangioma, but they don't rule out anything else. They say it can be cancer, it can be metastasis, it can be anything. And then this is the patient who's now been nervous and anxious for 3 weeks before she's able to come see the hepatologist because she doesn't know whether she has 6 months to live or what is going on. So what do you do next? Would you order an MRI with contrast? She's already had a CT. Do you think an MRI will add something? Would you biopsy the lesion? They've mentioned it's an hemangioma, so it's a little scary to biopsy a vascular lesion. Would you just follow this up with a CT in 6 months? She doesn't have too many risk factors. Maybe we can keep an eye on it. But she's symptomatic. Maybe it's the liver lesion causing the symptoms. So should we just resect? That way we help her symptoms and we also excision and we get the diagnosis. I'll come back to this in the end, but think about it. This patient, because she's 34, I think she's more straightforward, but you will see these in practice and it's not always so. So I'll start with an approach to, and to talk about benign lesions, I'll have to introduce liver imaging. So we know which test to order and how to interpret. We won't go into too much of the technical details like radiologists, but I think as hepatologists, gastroenterologists, all of us will have to be comfortable looking at these scans, interpreting which was ordered and knowing which one to order next. So let's start with some liver imaging. I'm not going to talk too much about ultrasound. It's usually the first investigation. It usually has been done before the patient is coming to see us. There are some lesions that you can detect on ultrasound that you don't really need to do the next thing. For example, a simple cyst or a small hemangioma in a low-risk patient. But in general, for most other scenarios, you would have to follow up a liver lesion with the next imaging. A triple phase CT is an excellent modality, is widely available, relatively cheap. Insurance in general will cover that, and it can characterize multiple of these lesions. MRI is the best imaging in terms of specificity for diagnosing liver lesions. So we'll talk more about these different modalities briefly. So this is an important slide to understand when we get the report and we read the body of the report to understand what's going on. This talks about phases of contrast imaging. We talk about triple phase CTs, quadruple phase CTs. What are we talking about? We're talking about timing of imaging in relation to contrast injection. So there are 4 phases that is shown here. The early arterial phase, which is 6 seconds after the contrast is injected. Late arterial, which is in general the arterial phase, which is around 30 to 35 seconds after the contrast injection. At this stage, you are seeing lesions which are being supplied by the hepatic artery. Then there is a portal venous phase. This is the phase the entire liver is lighting up because most of the liver is supplied by the portal vein. And there is a delayed phase around 6 to 10 minutes later by which the time the liver should have washed out. So in an early arterial phase, you will see lesions that are actively bleeding, like an aneurysm or an arterial bleed. In the late arterial or the arterial phase, you see lesions like HCC, hemangiomas, adenomas, anything that is being supplied by hepatic artery. Most other metastatic lesions, cyst, abscess will be seen on the portal venous phase. In the delayed phase, only lesions that can retain contrast. So think of fibrotic lesions like the scar edge or a cholangiocarcinoma. These have fibrosis, so they're retaining the contrast. Those will be seen in the delayed phase. And when you go through the body of the report and not just the final impression, and if you look at the different phases they mention, it'll give you a clue. And also when you order a scan for follow-up of a liver ultrasound, remember not to just order a CT-IV contrast, which is looking at the portal venous phase, but to order a triphasic because you get information on etiology by doing a triphasic study. And timing of and speed of contrast is important. Look at this scan here. The first image there, they imaged the patient 18 seconds after they injected the contrast, so a little bit early, and you hardly see the tumor there. But if you appropriately time and image at 35 seconds, which is supposed to be the arterial phase, you see that huge infiltrative HCC. So when you look at outside scans, a lot of times we'll end up repeating it because they didn't time it well. And also, it's important to give the contrast at the right speed. So if they place a very small IV or the IV blows and they're giving it very slowly, you might not see it. If you see the top panel, they gave it at 2.5 ml per second, and you hardly see any lesion. They replace the IV and they give it at 5 ml second with a larger bore IV, and you can see that there are multifocal HCC lesions that light up. So it is crucial to get a good quality study, and you can miss these just because the study was done quickly or inappropriately. In terms of MRI, I'll just introduce one brief thing about MRI. In general, we use MRI with gadolinium, but we should know about this hepatocyte-specific MRI contrast. Gado, I just call it EOVIST. So EOVIST, the special thing is it's taken up by hepatocytes and excreted in the bile. So if you do a delayed phase at around 20 minutes after contrast, EOVIST is going to any lesion that took up EOVIST is going to show up in the delayed phase. So it helps you differentiate certain lesions that can and cannot take up EOVIST, and I will show you where it's helpful. So now that I've finished a little bit of intro, background, I'll be showing a lot of images so you'll understand more about that. I'm going to talk about the 4 most common benign lesions. One is hemangioma, FNH, adenomas, and briefly on cysts. There are other lesions like angiomyolipomas, some pseudotumors. Those are rarer. I'm not going to go into those today. And I'll also briefly introduce to you the main questions patients ask me after they've asked Dr. Google when they found that they have a liver lesion. And I'm going to try to answer these same questions for every benign lesion because it's pretty much the same. Will the tumor grow? Will it turn into cancer? If it's a female, young female in whom these tumors are common, do they need to stop their oral contraceptives? Is it okay to go ahead and get pregnant? Do we need to keep following this with serial imaging? And should we just get it surgically removed? These are the usual questions which are common to these tumors, and I will answer this for each of these 4. So let's start with hemangiomas. In terms of a mass lesion, the most common benign mass lesion in the liver is a hemangioma. Like I said before, it's around 5% of patients it's seen. All of these, including hemangiomas, more common in women, and usually it's single. So on a CT scan, there is a quick way for you to know if this is a hemangioma. It's called a blood pool sign. Every phase of imaging, compare the contrast in the lesion to the contrast in the blood vessel, and it should be the same, then it's a hemangioma. So if you look here, I don't know if it has a pointer. Okay, maybe a point like this. It has one?
There's a red button and like the, you see that one?
A
little bit higher.
This one. See, but it doesn't show. Oh, there, yeah, okay. So this is a non-contrast. You see there's a hypodense lesion. In the arterial phase, you see there's a peripheral enhancement. The center is not enhancing. And compare it to the aorta here, it's kind of the same. In the portal venous phase, it begins to fill in. And you see the color here is the same here, right? And it's beginning to fill in. And in the delayed phase, it's washed out. So you don't see anything here. You don't see anything in the blood vessel. So it's called the blood pool sign. And as long as you see that, you can be a little confident that it's likely a hemangioma. So hemangiomas fill from the outside to the inside. So the periphery lights up first, and then it pools inside. So the MRI is even better at diagnosing a hemangioma than a CT scan. In a T1 phase, it's hyper intense on T2, hypointense on T1. And in an arterial phase, you can see here in the outside, there's like it's a discontinuous peripheral enhancement. Portal venous, it's filling in, and delayed phase is completely filled. So if you see that pattern in those 3 phases, you can be more confident. And the blood pool sign applies here too. What about an ultrasound? In general, it shows up as a hyperechoic mass, well demarcated, homogeneous on an ultrasound. And if an ultrasound shows a small typical hemangioma, in general, you don't need to follow that up. The diagnosis can be made on an ultrasound. There are specific scenarios where you should follow up. One of them, they looked at that in the study. They studied 213 patients who had hemangiomas. They did ultrasound, followed up with a CT, and saw how many were like wrongly classified, and they only found 1, which is reassuring that in most cases, the ultrasound is sufficient to make a diagnosis. The particular scenarios, I would be more cautious. One would be cirrhosis. I would like to emphasize here that any lesion in a cirrhosis patient is HCC unless proven otherwise. So even if the radiologist tells you it is a hemangioma or an adenoma in a cirrhotic background, you have to follow that up with cross-sectional imaging. So cirrhosis is one condition, and if they have known malignancy, or if there are any atypical features that they mention in ultrasound, I would follow those up with cross-sectional imaging. And when I say atypical hemangiomas, I'll show you a few atypical hemangiomas. This is a giant hemangioma. It's anything more than 5 centimeters is considered giant hemangioma. This one has a central scar that doesn't take up contrast, and this one has central calcification. So any of these features are considered atypical. What do you do if you have atypical? As long as the diagnosis otherwise is certain, you can wait and watch and do your serial imaging maybe once, demonstrate stability in size. Surgery only if it's causing symptoms that you can directly attribute. If it's compressing on a bile duct, if it's causing pain by stretching the capsule and it's large. So there are specific scenarios where you might have to consider surgery, but in general, you don't have to. And I mentioned this briefly about cirrhosis and hemangioma. So the question is, if you get that report, what do you do? And this was a study that looked at 44 lesions that were found on ultrasound in cirrhosis as hemangioma. They followed this up with cross-sectional imaging. So what did they find? Of these 44, it's a small study, but of these 44, on CT scan, only 33% were actually hemangiomas. Then they did RBC scan, which is very good for hemangiomas, and another 28% were hemangiomas diagnosed that way. This still is just a little more than half. 28% turned out to be liver cancer on biopsy, and another 11% was dysplastic nodule. So almost half of the hemangiomas that were diagnosed on ultrasound landed up being either a HCC nodule. So this is a reason to follow up hemangiomas that are seen on ultrasound. And then you saw that a bunch of patients were biopsied in that study, and in general, when I refer a patient with an atypical hemangioma to interventional radiologists, they're very leery of going forward. And nobody's really studied this. This is a study from 1988. There were only 15 patients considered to have some other risk factor, so they biopsied these 15 patients. They confirmed diagnosis in all 15, no complication in all 15, which I guess is reassuring, but a small study from 1988. In general, I try not to biopsy as long as I can get RBC scan or MRI to confirm diagnosis by imaging. But if you have multiple atypical features and they're high risk, it is still a reasonable option. I don't think we should shy away from that. So let's come to the questions that I said. In general, patients ask, hemangiomas, will they grow? Generally, they do not grow. Malignant potential, none has been reported. Oral contraceptives need not be stopped. I've seen many patients who the primary care physicians, any liver lesion, they just ask them not to take OCPs. You don't have to do that for hemangiomas. The patients can go ahead and get pregnant. There's no risk with this. Generally, I don't perform serial imaging, just one cross-sectional imaging, confirm diagnosis, and there is no need to every 6 months do ultrasounds and MRIs on these. And as I mentioned already, you don't need to surgically resect these unless they're causing compression or other symptoms. So let's move on to the next one. Another one relatively common in practice, focal nodular hyperplasia. This prevalence around 4%, again more common in women, 8:1. And this is a benign lesion, it's polyclonal. What it is you see the central scar here. Usually there is an arteriole or a blood vessel here that was surrounded by fibrous tissue and regenerative tissue. And this is how it looks on gross, on gross imaging. And this is how the histopathology, you see fibrous septae and scar tissue. So now that you see in this image, you can now visualize it on imaging, right? It looks exactly how you would expect it to. The central scar on the arterial face does not take up any contrast, but there is nice brisk enhancement in arterial face, which is why this a lot of times gets confused with HCC because of the arterial enhancement. But on the venous face, you really see isodense, and on the delayed face, you do not see washout, which is the important difference, because HCC will wash out. And the scar enhances or retains contrast in the delayed phase. And MRI, it's even more obvious. So phase, it's enhancing. Portal venous phase, it's isodense. Delayed phase, the scar can retain contrast. And this is very important. This is a hepatocyte phase. So if you use EOVIST contrast, which is a hepatocyte-specific contrast, these are made of benign hepatocytes, and they have biliary architecture inside them because it's just a benign regenerative tissue. So it will take up EOVIST and will be bright in the hepatocyte phase. And this is a good way to differentiate this from an adenoma, which is actually a tumor more likely to be monoclonal, and those don't have biliary tracts, and those don't light up on the biliary phase, on the hepatocyte phase. So if you see a benign lesion, radiologist calls it FNH, possible hemangioma, possible adenoma. Using EOVIST is a good way, without having to biopsy, to differentiate between these entities. So FNH, what's the prognosis? This was a study a while back of 216 patients. Followed these patients for 9 years. And what they found was neither the size nor the number of FNH lesions are influenced by oral contraceptive use. This is not a hormone-sensitive tumor. Size changes during follow-up are rare and do not seem to depend on oral contraceptive use, and pregnancy is not associated with changes or complications. So this is, again, very important because most of the FNH patients who come to my clinic are already been taken off their oral contraceptives. So for the questions that they ask, will it grow? In general, no. They can actually regress later in life. Is there malignant potential? None has been reported. If you confirm the diagnosis by appropriate imaging, they really don't have to worry about this. Do you need to stop oral contraceptives? Generally, no. And the reason I say that if they're continuing, it's reasonable to re-image, is there is still an outside chance that you made a misdiagnosis of an adenoma as an FNH. So I like to image them, those patients who remain on oral contraceptives, once or at the most twice, just to ensure stability in size and confirm the diagnosis further before I tell them that they don't need to keep surveillance. So the only time I do serial imaging are these larger lesions, oral contraceptives, pregnancy, and that's only because I want to confirm that it is truly an FNH and not an adenoma. If I have a biopsy-proven adenoma, I do not, biopsy-proven FNH, I do not worry about it. Let's move on to hepatic adenomas. Hepatic adenomas are relatively rare, actually quite rare, like 1 in a million benign lesions. They began to, I saw the case report started coming out when the oral contraceptives, the high-dose estrogen oral contraceptives were introduced in the 1960s. And since then, there's been a clear connection between oral contraceptive use and adenomas. These occur in general in young women, strong association, 40-fold risk increase with OCPs. When you biopsy these lesions, they just look like bland hepatocytes. And this is a normal tumor, normal liver, and this is an adenoma. And you can see that the cells are probably similar in size and shape. They look like hepatocytes, but these are positive for beta-catenin. That's the nuclear staining you see here compared to this. So if you see an adenoma in a cirrhotic liver, it is very difficult to distinguish that from a well-differentiated HCC. You don't even make the diagnosis. You would call that a well-differentiated HCC at that point. So adenomas are benign, but which is a regenerative lesion. this actually is a benign tumor. On a CT, there are multiple different kinds of adenoma, so there can be variability. But in general, they enhance. They become isodense on the portal venous face, similar to FNH, but they don't have a scar. That's one way to look at it. And this is where the MRI with EOVist was very helpful. Ignore this one. This is a cyst. So the lesion is here, T2 here. T2 on T2, it's bright. And on arterial face, it's enhancing. On portal venous face, it's just isodense. But here is the big difference. On hepatocyte face, it is not taking up contrast because this is a tumor. It does not have biliary architecture. It does not excrete the EOVist into the biliary tree then, so it doesn't take up. So FNH on hepatocyte face will be bright and adenoma will not be. And between these two lesions is usually where we have a problem making the difference, and instead of biopsying, we have a great way to now image this. In the field of hepatic adenoma, interestingly, there's been a lot of very interesting research, and it's one of those few tumors that have a very classic genotype-phenotype correlation, which we've been trying to achieve for HCC, which is much more genetically complex. In the case of hepatocellular adenoma, there's a group in France who have done a lot of very interesting work. They showed that there are 4 different types: steatotic, beta-catenin activated, inflammatory, and the others that are not classified, another 10%. All the steatotic ones have loss of LFABP on immunohistochemistry, and all of them have HNF1A mutation. The beta-catenin activated ones are positive for nuclear beta-catenin on immunohistochemistry. These are important to identify because they have a very high risk for malignant transformation. The inflammatory adenomas are positive for CRP or SAA on immunohistochemistry. So if we get a biopsy, by using 2 to 3 immunohistochemical stains, we can classify them into one of these 3. Why is it important? Because I have some patients who cannot have it operated, cannot have it resected, and I want to tell them what the risk is. Or some patients who don't know whether they need the surgery, and when I biopsy larger lesions, if they're beta-catenin negative, I'm more comfortable following them and not sending them for surgery. So at least we have a test that helps us. So in these special populations, if the tumor is larger than 5 centimeters, if the patient's symptomatic from the tumor, if the beta-catenin is positive, or if it is a male patient, these 4 are clear indications for resection. The risk for malignant transformation to HCC is very high. It's around 30%. And it's just difficult to diagnose when the transformation happens because it's a nodule and nodule appearance, and you could easily miss it on imaging. So these 4 groups of patients, I strongly counsel them to have resection. That's the best way to move forward. There are, of course, exceptions where we try to survey them. What about women? Yeah, that's tricky because in general, most of the patients who have symptoms it's unrelated. It's dyspepsia or some other reason that they have symptoms. If there is a large tumor, like greater than 5, and it's subcapsular, causing stretching of the Lesionss capsule, and they have a very focal pain, that to me, on history, seems convincing that it's coming from there, I would consider that as direct symptom. And it's challenging to attribute it. If you can see that the symptoms are worsening and the tumor is growing, some temporal association, then I would say you can attribute the symptom to the tumor. The more common scenario we see is the women with the small 2 to 3 tumors. They're on oral contraceptives. What do you do for those patients? I ask them to stop the oral contraceptives, use the alternative method for birth control. If they cannot stop oral contraceptives, I have some patients who absolutely need it for either dysmenorrhea or other medical indications. Then I monitor them every 3 to 6 months to show some stability. And if I see that it is growing while on oral contraceptives, and if they absolutely need OCPs, then it's better to have it resected even when it is small. Another important thing to remember is the risk for hemorrhage during pregnancy. Even small adenomas, and especially larger than 5 centimeter, they can bleed profusely during pregnancy, and it can be catastrophic. And this is a population, young women, we are asking them to stop oral contraceptives. So you're putting them at risk for pregnancy, and then that's a big risk. So for women who want to get pregnant, I do counsel them to consider resection prior to pregnancy. And if they are already pregnant, and that is when it is being diagnosed, and if it is greater than 5 centimeters, it is, of course, an elective surgery in a pregnant woman, but I think the alternative option of watching it and having a potential bleed, catastrophic bleed, is even higher. So if it is a larger than 5 centimeter in a pregnant woman, we would still recommend resection electively in second trimester. Again, this is a rare tumor. We don't have randomized controlled trials where they followed a pregnant woman with an adenoma. So this is a risk discussion with the patient and the family to make a decision. So for this tumor, the answers are slightly different. Will it grow? It will likely grow if you continue to stay on oral contraceptives. Is there malignant potential? Yes, it can turn into HCC, 3 to 5% overall, but in specific groups, it's even higher. Should one stop OCPs? Generally, yes. And if they are continuing, you should continue to image them every 3 to 6 months. Does it need serial imaging? Generally, yes, because either you're considering continuing OCPs or you want to show stability in size. So most of these times, I'll end up seeing these patients for a few years. This is the only abstract that I told you about that I found in the current AASLD. They try to develop and validate a model to predict regression of adenomas. So they used the initial diameter at the time of diagnosis, the subsequent diameter after 6 months, and the subtype of HCA. I told you there are 4 subtypes. They gave different points to different subtypes, and they came up with a score, and they made a calculator. This is an abstract. I think the manuscript needs to be published, and subsequently we can maybe use this score to counsel patients. Okay, moving on. So we are here to the last group of lesions. These are not tumors, these are more lesions. Very, very common. I still get referrals for these. But the hepatic cysts, just thin-walled, they're usually single, usually simple. You can find them you can just make the diagnosis on ultrasound. Of course, on a CT, that is how they appear, hypodense lesions. The complications of cysts, though, the complicated cysts are important to identify. One would be a septated cyst, because we are worried about cystadenoma. And cysts can grow and transform to cystadenoma, or you can have a de novo cystadenoma, and these should not be missed. So if you see a septated cyst, if you see a cyst with a thick wall, that can be a metastatic cystic lesion. So whenever you see a wall like that, you should worry about it, and further investigations need to be done. And then cysts that have daughter cysts inside them, cysts that have bleeding inside them, these are complex cysts. So septations, thick wall, internal hemorrhage, daughter cysts, mural nodules, all this should raise concern for either cystadenomas or cystic metastasis. And the evaluation of this is complicated because they've studied whether you can do a cyst aspiration and study tumor markers in that. That's not very effective, and it is difficult to biopsy just the wall of the cyst. So in a lot of these patients, if it is in the right location and the suspicion is high, we'll end up sending them for an excision and then make the diagnosis. So in general, though, those are very rare. In general, cysts do not grow. There's no malignant potential if it is a simple cyst. There's no need to stop oral contraceptives. They can go ahead and get pregnant if they wish. And when you see a cyst and the diagnosis is clear, there is no need for serial imaging, and there's no need for surgical excision of a cyst. So this is a diagnostic approach to liver lesions from the ACG guidelines. It's a little different from each practice depending on which modality of imaging is good at your center. But broadly what they say is if you have a liver lesion, it is important what is the pretest probability. So what is the risk factor for HCC? Do they have a previous history of malignancy, so you need to worry about METs? Is there some symptoms like weight loss, early satiety? So if they have these, if they're a high-risk patient, you definitely should follow this up with a dynamic CT or MRI preferable. And this will likely give you the diagnosis. Is it a HCC? Is it a metastasis? Is it other? And obviously, you can go forward from there. If they don't have any risk factors, they're young and they don't have comorbidities, then it is called that term incidental loma. And you're suspecting at this point a benign lesion. So if it is a cyst, an asymptomatic cyst, there's nothing to do, just observe. If it's a hemangioma, nothing to do. If it is a complex cyst, then you have to investigate, like I mentioned. These are lesions that, in my early training in India, I saw a lot of amoebic abscesses, hydatid cysts. I have seen only one hydatid cyst here. This is differential here. But if the incidentalloma is solid, you should still pursue a CT or an MRI, preferably an MRI, to make the diagnosis. If they have a central scar, and if they have that uptake on the EOVist MRI, it's a FNH. No scar, no uptake on EOVist MRI, it's an adenoma. And adenoma, further you need to discuss more regarding size and risk. But this is the approach for if you see a liver lesion on an ultrasound. What do you do from there? So going back to our patient, if you remember, she had a lesion on ultrasound that had showed up on a CT. It was called an atypical hemangioma. The best thing to do for her would be to order an MRI with contrast. The American College of Radiology says for imaging liver lesions, MRI should be considered because for any indeterminate liver lesion, because it has higher specificity and sensitivity. And I showed you some data that biopsy of hemangioma is safe, but should be reserved when imaging findings are truly indeterminate. You've tried all the imaging modalities you can. And if the MRI says this is a typical hemangioma, you don't need to do any further follow-up. And the last point is important. I think I already mentioned it. A lot of my patients actually develop symptoms after the diagnosis of the lesion. Someone tells them, oh, you have a 2-centimeter cyst, and now they're like, yeah, I do feel something there. So a lot of symptoms are unrelated. They lead to the diagnosis of these incidentalomas, but they are usually either cholelithiasis or dyspepsia. So before attributing the symptom to the lesion, there should really be substantial evidence for that. So take-home points. The first point I cannot stress enough. I've seen these lesions that have been missed. All lesions in cirrhotics should be considered HCC unless proven otherwise. And a good quality triphasic cross-sectional imaging, CT or MRI, can establish diagnosis. Most of these lesions don't need to be biopsied. But if you're at a point where you've done multiple imaging and it's indeterminate, do not hesitate to biopsy. The data, the safety data for liver biopsy of these lesions is pretty good. And it's important to know the natural history of these lesions so we can counsel them regarding oral contraceptives, pregnancy, surveillance. Because even though, and for us it's like, oh, this is benign, you don't have to worry. I walk in and I see the patient, they're just sitting on pins and needles, they're so anxious. All they know is they have a tumor in the liver. So it is actually a burden for them, and it's important for us to be able to reassure them, for which we need to understand these lesions. Thank you.